Hello. Hi. Can everyone hear me? If someone could just put something in the chat and just say yes. If so, we can try and make a start in the next few minutes. Okay, perfect. Someone said yes. Okay, so I will go off that and I'll assume that all of you can hear me. Sorry about the slight delay. We'll make a start just because I don't want to take too much of your Thursday evening. So my name is Dr. Bashir. I'm currently an FY1 finishing off just my final rotation on ED. And I'll be moving on to FY2, where I'll be starting on general surgery. I'm currently rotating in Southwest Midlands, in Worcestershire, but I have friends all over the country. So this is all like kind of experiences collated, not just from myself, but also from my colleagues, friends, and also some seniors as well. So I've got input from a whole range of people to try and make this as beneficial as possible, and just basically kind of hone in on the main things that are really required to know, and kind of filter out all the white noise in the background. Thank you all for joining, and hopefully it'll be worth your time. So basically, we'll just be focusing on the on-call shift as an FY1 specifically, and we'll be looking at the daytime ward cover. That's the shift that we'll be focusing on. However, there will be future talks about night shifts and clerking shifts, etc. And we'll just touch upon these as we go on. And sorry, I'm just going to, by the way, just during this, I'm going to have a quick look at the chat as well. So just one person said, hello, will this session stay on the channel in the live section? Yes. So in terms of watching this later on, this will be automatically uploaded onto the Mind the Bleep YouTube channel. If you can't, make it live, or you have to cut halfway through the session, you can always refer back to this at a later date. So, what is an on-call shift? So, essentially, it's just any shift that is outside the normal working day or the usual working hours, right? It usually consists of you being outside of your base ward that you are usually on a day-to-day basis. And the expectation is that you'll carry a bleep and you'll be responding to any urgent or emergency clinical issues that kind of crop up on the wards that you're allocated to on your on-calls. So usually what happens is, let's just take me, for example. I started on a cardiology rotation early on in my FY1. And essentially it was usually a 9 to 5, but then some weeks I'll be on call. So usually during that on call, the on call will be from 5 to 9 o'clock. So usually the expectation is that I carry out, my normal working day, do the ward jobs and everything like that, which we'll talk about. And then at 5 o'clock, I'll pick up a bleep. And then from 5 to 9 o'clock, I'll be allocated a ward to look after. That may be the cardiology ward that I'm on, but it wasn't in my case. It was actually a geriatric ward that I had to cover and that I was allocated to. And that usually is the case at FY1. Usually you're only allocated general medicine wards as opposed to specialist wards. But again, we'll talk about all this later. So in terms of the different types of on-calls, I did touch upon this. They usually include the daytime ward covers, the nights, and also clerking shifts. One of the other shifts that you might hear sometimes crop up is called the post-take shift. However, this is usually only allocated to FY2s. But again, this is really dependent from hospital to hospital. So I'm just trying to essentially just highlight generically or generally what it's like across the country. But there might be various anomalies throughout, especially if you're in very isolated areas in the country. So as an FY1, and this is really important to understand, apart from the clerking shifts, right, and this only really goes to the daytime ward cover, you're only expected to see patients who've already been seen by a senior registrar or consultant during that day. And that means that all these patients that you're seeing on the wards, they would have already had a ward round and therefore been seen by someone senior. And therefore, there should already be a plan in place for them, which makes your life a lot easier. And that's just something to bear in mind. Now, I think one really important thing to touch upon, just before we go through anything, and talk about the shifts and everything, is just to understand really the hospital care process, to understand where you guys are in the pecking order and who you're taking care of exactly. So, essentially, usually patients come through three different ways. Usually by the GP, by the and they're referred into a GP. They present directly at the emergency department, or they could present for any kind of secondary care service, for example, any kind of outpatient clinic, such as a gynecological outpatient clinic or urology or anything like that. And all these patients then usually funnel through the emergency department, and then they come through two departments, or they come into two places once they're admitted into the hospital. And usually this is the same day emergency care unit, or the acute medical unit. So the same day emergency care unit is just like basically any patient who's able to walk and mobilize, and they're very stable usually, and they can be seen in the same day emergency care unit, are usually the specialist doctors of that unit. So for example, we have a medical same day emergency care in my hospital. We have a urology same day emergency care, and also a cardiology same day emergency care unit. So usually these specialist units will assess the patient and deem or decide whether they should be for admission or whether they can be seen as an outpatient. So usually these are the kind of patients we're unsure of. And then you have the acute medical unit, and this is where these patients have been admitted into the hospital, and this is just a kind of temporary ward, before they're then disseminated into other areas of the hospital, right? And from both these areas, the same day emergency care unit and the acute medical unit, right? Again, we can decide whether they will either be seen as an outpatient, they can be discharged, or whether they need to be admitted, for a longer period of time, and they can't just be immediately discharged. So usually these patients are admitted to a general kind of inpatient ward, so general medical ward, where you have all kinds of varying problems. And this is mostly dedicated to the geriatric population. But then also they can be admitted to a specialist ward. So for example, gastroenterology ward, a cardiology ward, as I said, for example, urology ward, and I keep mentioning urology just because my hospital is actually a urology specialty center, or for kind of the very, very unwell patients, they might be admitted to ICU. And that will really depend on the patient's fitness status as well. But we'll talk about that a bit later. The point is, and the reason why I'm showing you guys this, is because where you guys will be as an FY1 is you will be in the purple section, meaning that you will be, in terms of the daytime ward cover specifically, you'll be taking care of the patients that have been admitted to either a general inpatient ward or a specialist ward. Usually not ITU, that's only dedicated for anaesthetists. But yeah, as I said, the general inpatient ward and the specialist wards are the kind of wards that you guys will be taking care of patients on. And by the way, any questions about this, please pop them in the chat and I'm happy to answer them as we go along. So let's just quickly touch upon the other types of shifts just before we go on to the daytime ward cover. So one of the shifts, as I kind of talked about or alluded to, is the clerking shift. So what the clerking shift really means is these are patients who have been admitted through A&E, and they've made the decision, either the medical team or the surgical team have accepted these patients to be admitted in hospital. Okay, and the clerking is essentially you are the first person to touch base with this patient as part of the respective teams, either the medical or surgical team. So let's just take the medical team as an example, because I think most people will have at least one medical job throughout their FY1 or FY2. So essentially, these patients have already been seen by the emergency department for the most part, right? Unless they're already medically expected, and we'll talk about that. And these patients, usually as an FY1, you'll be asked to clerk them. And what do we mean by clerking? So clerking is basically kind of a bit repetitive on what the ED department have already done, but a slightly bit more and a bit more of a comprehensive plan for what we're actually going to do for them in hospital. So essentially, it just consists of taking a full history from a patient, obviously performing a full assessment on them as well, so a complete examination, a head to toe, and then formulating your differentials. Obviously, the ED department's diagnosis will help guide you, but they won't necessarily be completely right in their diagnoses, because obviously some investigations may have come back that the ED department have requested. And obviously, so therefore you guys will have a bit more of a holistic view on what's exactly going on with the patient, whereas the ED department kind of just hazards a general guess, right? And then you guys will order any additional investigations on top of what the ED department have already ordered. And the most important part is you guys will be expected to start the appropriate management for the patients. So let's just take an example. Let's say a patient has presented in the ED department with an infective exacerbation of COPD. And, the first thing that the ED department has done is they've tried to stabilize the patient. They've started them on nebulizers and stuff like that. And the patient has, been referred, and they start them on, their first dose of antibiotics, and then the patient's been referred. Then what we would do is in terms of starting the appropriate management, we would obviously make a more comprehensive plan in terms of the nebulizers, when we would step down from nebs to just inhalers, and also how long the course of antibiotics will be, etc. So it's really planning for their entire hospital stay, essentially. That's what the clerking process is about. And one other point to also consider is during the clerking, because of course, you're not expected to know everything as an FY1. It's really important to understand when it's appropriate to escalate to your seniors. And I think that is really going to be your savior throughout your FY1, which will be your senior house officers and also your registrars as well. So yeah, and as I said, we'll talk about this in a bit more detail in terms of how to escalate, who to escalate to, and also when it is appropriate to escalate. So the daytime ward cover. This is the shift that we'll be talking about throughout the rest of the talk from here on out. And there will be a talk later on in our series that will touch upon night shifts and what's expected there, which will be slightly different to the daytime ward cover, but I think that the principles are mainly the same. Now, in terms of the common questions, so I actually went around and I asked the FY1s, my colleagues, what kind of questions they were asking when they first, started F1, or when they were in their induction week, and what kind of things they were struggling with, and what kind of took them a bit of time to understand that would have been good to be highlighted, prior to actually embarking on their FY1. And these are kind of common questions that I came across. So just in terms of the rota, just asking questions about the hours and what the expectations are. Now, usually on a surgical rotation, the expectation is that it will be from an 8 to 8 in terms of the on-calls, whereas on a medical rotation, it's usually a 9 to 9, and that's throughout the country. But, you guys might have different rotas. How to prepare. So, going into the shift on a Monday and then finishing off on a Thursday, what kind of preparations are needed before each shift, and what kind of things you should bring with you in terms of your responsibilities as well, and what is really expected of you. And in terms of when nurses bleep you or other doctors bleep you as well to come and help, how do you respond? What are the main questions you need to ask? What are the kind of things that you should ask to filter out or triage in terms of priority, what should come first and what you should be seeing first, or what kind of comes at a lower priority, and things that basically should have been dealt by the parent team of the patients, and things that can essentially wait till tomorrow. And this also comes under prioritizing jobs as well. And very, very important is, how to deal with a deteriorating patient, and we'll talk about the principles of that as well. And then last but not least, when you're handing over to the night team, how to give an effective handover. And so the patient's, health and wellness is all maintained, and so nothing is essentially missing. And this is kind of the Swiss cheese model that they talk about. So there's multiple safety nets, and you are one of them safety nets. So you want to make sure that everything is handed over effectively and nothing is missed out. So, in terms of the rota, and I kind of touched up on this, it will really depend on whether you're surgical, you're medical, you're on a psychiatric on call, or any other on call. Now, just the thing to kind of hint at here is that a psychiatric on call and these kind of other niche on calls like hematology, etc., usually there'll be a 24-hour on call. Sometimes they're off-site, sometimes they're on-site. It will just depend. But usually, as an FY1 and FY2, it will mostly be off-site, and you'll only have to come in if there's something pertinent, essentially. And as I said, in this particular talk, we're only going to talk about the surgical medical on-calls. In terms of the on-calls themselves, they will usually start at either 8 o'clock or 9 o'clock, and the on-call will begin at the time that you pick up your bleep. Right. If we talk about medical and surgical on-calls specifically, I will talk about my hospital. So there are some on-calls that are from where essentially you pick up your bleep at 5 o'clock. So the end of your normal working day, you pick up the bleep, right? Whereas there are some where you're scheduled to pick it up right at 9 o'clock in the morning when you begin your shift, right? And usually that will depend on whether you are part of the crash team or whether you're not scheduled to be part of the crash team. And what that means is if you carry your bleep from 9 o'clock in the morning onwards, then you'll be allocated a resus role, and you'll be attending any of the medical emergency calls throughout the hospital during your day, right? And whereas the shift that begins at 5 o'clock in terms of the on-call, and that's when you pick up your your bleep at 5 o'clock in the afternoon up until 9 o'clock. For that shift, you won't be expected to attend any medical emergency on-calls. You'll only be expected to do the ward cover duties, right? Whereas the crash bleep is associated with going and attending the ward cover duties as well, and that is from 5 to 9. But then also throughout the day, you'll be attending any crash calls as they come. And you might be asking, what am I doing during my 9 to 5? During your 9 to 5, you're just attending your normal ward duties. So, for example, doing discharge summaries, seeing patients on the ward round, prescribing fluids, prescribing whatever it might be, antibiotics, analgesics, laxatives, etc. So that will be, your main responsibilities throughout the daytime. But obviously, as I said, when you carry the crash bleep, you'll be expected to attend any crash calls during the day. Whereas if you don't, then you'll only be expected to carry out the extra additional ward duties from 5 to 9 o'clock. Okay, hopefully that makes sense. It is a bit, a lot to digest. But as I said, once you guys kind of get into the swing of it, it will come very easily. In terms of the weekday and the weekend on calls, they differ slightly in terms of the responsibilities, and I'll touch upon that in the next slide. In terms of the day itself, as I said, it will just be extended beyond your normal working day. That's what an on-call is. And the commonest on-call shifts are usually a 12-hour long shift. So it's usually 8 hours or so on your normal working day, and then 4 additional hours of ward cover duty. And then that's followed then by a handover to the night team. And then usually this will be the rota for 4 days. So usually from Monday to Thursday, and you will get Friday, Saturday, and Sunday off. You're probably wondering, by the way, what this little logo is in the corner. That's just the My Duty app. And I will type that in the chat right now. Essentially, it is very, very useful, in my opinion, for kind of tracking your rota and putting everything down in terms of your hours and everything. And it kind of just helps you plan time, and especially with your colleagues as well. If you all kind of put your rotas on this app, you can view other people's rota and you can kind of plan holidays, etc. So this is kind of just a bit of a tip just for you guys, just to be a bit more organized and kind of prepare for your FY1 properly. So, talking about preparations, I would say that all these apps that you can see on the right-hand side of the screen are going to serve you very, very well throughout your foundation years and beyond as well. I see even consultants with all these apps, actually. Even Geeky Medics, surprisingly, I've seen one consultant with it. Because, you're not going to remember every single examination ever. And the kind of, all the niche, kind of procedures and all these kind of things. So it's quite useful to have. And I'm just going to talk about each one very quickly. So Toxbase is for any overdoses or anything like that, especially very niche ones. For example, I had a patient with a phenytoin overdose, and they actually presented very, very much like a stroke. But thankfully, we saw that they were on phenytoin. We measured the phenytoin level, and then we realized that it was just simply a phenytoin overdose. And then we managed based off the Toxbase guidelines. So these are UK guidelines of how to handle overdoses. So it's going to come to you very, very useful. MD Calc, the reason why we use this is essentially just for the scoring systems. So, for example, when you want to calculate a Wells score, and therefore justifying whether to do a D-dimer or not for a suspected PE. Also, as well, you can have the heart score or the TIMI score, and that's to basically see the risk of patients, whether we should treat them for acute coronary syndrome or not, and all the kind of other varying scoring systems such as the HAS-BLED, and all these kind of other things as well. So that will come very, very useful. The other ones as well, microguide. So essentially what microguide is useful for is looking at the antimicrobial guidelines that are specific for your hospital. So you enter the trust that you're at in the app, and then it will load all the micro antimicrobial guidelines. So essentially the antibiotics that are best recommended for particular things, such as, for example, flucloxacillin for cellulitis, or the second line management for someone with C. diff, stuff like these, kind of these little niche things. So it's very, very useful to have and have on you, because you don't really want to be searching these things, when you're in an acute scenario. And the other things to look at as well is ACCX. So that is the one on the far right. And essentially, this app is very useful for having all the bleep numbers for your hospital. So again, you just type in the hospital that you're at on this app, then it will come up with all the bleep numbers. So you have them all at hand and you know exactly who to contact and when. The other things that are available, so you have the NHS Blood Assist. This one is essentially just for blood transfusions. So I think the main thing that I've ever really used this for is how to treat a transfusion reaction. And that can happen, it's very rare. Also, you can maybe look at the blood products and just in terms of the patient's blood type, and then what kind of reacts with that blood type and what doesn't react. But I think a lot of these things you would know from medical school in anyway, but maybe it's a good refresher too. In terms of geeky medics, I think everyone is probably well aware of what geeky medics is, especially after going through the OSCE process. Essentially, I only really use it just for looking at particular examinations, very niche ones. So, for example, I had a patient who had a suspected posterior circulation stroke. So I would use geeky medics just to do the HINTS exam and just to see, because the patient had some nystagmus. So essentially seeing whether it was a central cause of the nystagmus or a peripheral cause. And that can be very important in distinguishing whether the patient would have had a posterior circulation stroke or not. And then the other last two is EOLAS Medical. So this one basically is just for all your hospital guidelines. So, for your respective hospital, the guidelines for COVID, etc., and all these kind of weird and wonderful treatments. And then last but not least, the BNF. And that's, obviously the saving grace. That is the one that you probably refer to, on a day-to-day basis, but sometimes you can use a hospital guidelines as well. It really just depends what for. But just for drug dosages and all these kind of things, the BNF is an absolute godsend. So these are kind of apps that I've got all downloaded on my phone. But feel free to let me know in the chat if there are any other things that you guys have discovered, because they kind of release these apps on a quarterly basis, and there's all weird and wonderful things that people come up with. So yeah, let us all know if there is anything useful that I haven't stumbled across yet. Now, just the other quick preparations: bring a pen and paper with you, because you're going to have to write down all the patient's details from the handover for whatever you do get handed over at 5 o'clock, and also for whatever you want to hand over at 9 o'clock to the night team. So this is going to be very important. Of course, rest, relax, get some good sleep. You don't want to be making any mistakes when you're on your on-calls, because they can come back to haunt you. And attend early for your morning handover. You really, really do not want to miss anything that's been said in the handover, because there might be some very pertinent patient details that you miss, or any investigations or results to chase that you've missed as well. So just make sure you're there early, prepped, and yeah, you go from there. And then one last thing: if you are attending the crash call, please get familiar with what your resus role is. So introduce yourself to the team. I'm an FY1. I'm on this, rotation currently, and then they will allocate your resus role. Usually, the medical registrar is the one who's leading these, medical emergency calls, and he'll be the one to allocate you. Most commonly, as an FY1, you'd only really be expected to be a scribe. However, I have, had to do chest compressions before as well. So I would say get prepared for anything, especially once you finish your ALS course as well, if you guys have already done that. But then you'll be expected to maybe step into more, important resus roles. Now, in terms of the responsibilities, so as I said and kind of alluded to, the weekdays and the weekends can be a bit different. So usually on the weekdays, as I said, you can collect the bleep either at 9 o'clock or at 5 o'clock in the afternoon, depending on whether you're on crash call duty or not. And then usually you just present at your base ward in the morning. You carry out your ward jobs. It's like a normal working day. And then from 5 to 9, you're doing any kind of urgent ward issues that come up on the wards that you're allocated to. So as I said, this will usually be a general medicine ward that you're allocated to from 5 to 9 o'clock. And essentially, what else? The main thing is, as I said, you cover your out of duty ward hours, and then you just hand over to the night team. However, on the weekends, it might be a bit different. So on the weekends, it will be a different allocated ward than the ward you're usually on the weekday. So it's not going to be your base ward. And you'll have to carry out the ward jobs on this new ward, right? And be expected to carry out that and then you will then have to attend to any bleeps from that particular ward throughout the day. But the good thing is about these kind of shifts is you familiarize yourself with the patients more, because you're already obviously doing the ward round. You're getting to understand and know their plans, and obviously you familiarize yourself with the nursing teams as well, as the year goes on. So essentially, these kind of shifts, you shouldn't expect as many bleeps during them, or as many complicated bleeps, I should say, because you should be already kind of accustomed to which patients are going to be difficult to deal with, and what patients are most likely to be you're most likely to be bleeped about, etc. So, responding to bleeps. So, we're just talking about how to receive bleeps first, and then and how to respond to them, and then also what the common bleeps you should expect. So, in terms of receiving bleeps, so firstly, you're supposed to ask a kind of set of questions to the nursing staff who will most commonly be the ones bleeping you about a patient, because you want to know essentially what do they want you to do. Okay, what are they expecting you to do when you're coming to see this patient, and what is the escalation plan for the patient, and what if this goes wrong, etc. So the first thing that you want to know is, where is the patient? What's the patient hospital number as well? Because then what you can do is, if you're at a computer that's maybe remote, you can kind of search up the patient on your system, see exactly how the patient has been, what the report on the ward round was previously during the day, just to kind of get an idea of what could be going wrong with the patient and why they're calling you about that particular patient. Because sometimes the detail is missing over the phone. Then you'd ask them what actually is the issue. So what are they really expecting from you? Why do they want you to see this patient? Is the patient deteriorating? What are their observations? What have their recent investigations been? And just really getting to the point of, why do they want you to come all the way up to the ward and see this patient and review him for? Okay, and and I think this is the most important question, and I hope that the main takeaway message, if you're going to take anything away, is this: please, 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 always emphasize what is the patient's baseline. Okay, because you have to keep in mind, these nursing staff, essentially, they will start at 7 o'clock at night for their night shift till 7 o'clock in the morning. So that leaves around 2 hour gap from 7 till 9, where you'll be called about patients, and they won't really know the full story of the patient, right? And so it's very, very important that you do. And what do I mean by this? So, for example, they might call you and they might say, a patient's blood's come back and the GFR is in the 50s, okay? And they're worried, and they want you to review the patient. Now, of course, that might indicate that the patient is in an AKI, but most likely, especially for an inpatient and that hasn't been treated, most likely it's probably just a CKD3 A or B, okay? And you really want to know, what was this patient like before? And that's what we mainly go off, okay? For example, if the patient's observations, their saturation is a bit on the low side, right? But they've been like this throughout their entire hospital stay, you're not going to intervene, okay, in that case. So when you're called about these things, it's very, very important to get a bit of a picture of how the patient has been like throughout their entire admission, and what the patient is usually like on a day-to-day basis. Has there been any sudden change? Because that's the thing that you're mainly looking for and looking to treat, especially on a night shift or on a daytime ward cover where it's out of hours, right? We're not trying to perform any miracles here, okay? We're just trying to get the patient better, or get the patient stabilized throughout the night so they don't deteriorate. Okay, that is your main concern, and that is your main responsibility as well. Okay, the other thing to also ascertain from the nursing staff is, what is the escalation plan? And what we mean by this is, what is expected of you if you are to come and see the patient, right? How far are you going to go with the patient? And what that means is, for example, is a ceiling of care just a ward-based ceiling of care? Are you only expected to, for example, if the patient's deteriorating, just to treat them with antibiotics, fluids, and other kind of pharmacological interventions? Or is the patient fit and healthy, and if they do deteriorate, there would be for ICU admission, or even more invasively, for open surgery? So again, this is very important to understand. Or, for example, is the patient at end of life care, and therefore there wouldn't really be much you'd be doing for the patient apart from keeping the patient comfortable. So it's these kind of things that you also need to think about as well, and think about asking the nursing staff before you go up to see the patient, just so you get a bit of a clearer image of what you're actually going to do when you go and see this patient and when you go and approach them. A few other things as well, just to note, is also what has been done so far. So what has the base, ward or the medical staff during the day, what have they already done for the patient? to manage the patient. And that's also so you know kind of what is left to do. Okay, or what can you do? For example, if antibiotics or IV antibiotics have already been given about a couple of hours ago, then you're not going to be giving IV antibiotics again, are you? So there's a very limited amount that you can really do in that kind of scenario if the patient starts spiking a temperature or anything like that. Okay. However, if the patient, it's the first time that they're spiking a fever, then you'd go through the motions. You'd do, blood cultures. You would maybe do a set of bloods as well, and you would more closely monitor the patient, and then begin to start them on IV antibiotics and stuff once you've done the relevant other investigations such as a urine dip, maybe a feces sample as well, etc. Okay, so these are really the things to consider too. Now, in terms of the most common bleeps, the things that you will be very, very likely to, if not most certainly, be called to. So, number one, prescribing, very simple medications. And most of you guys, if not all, would have done your prescribing safety assessment. So, you'd be expected to do these kind of things. So, such as laxatives for a patient who's complaining of constipation or a bit of abdominal pain. Pain relief as well, and also antipyretics, so prescribing some paracetamol for patients who are feverish, antiemetics as well, for patients who feel nauseous, fluids, so these can be repeat prescriptions of fluids, or if a patient's blood pressure is low, maybe you'd do a first prescription of fluids and see how the patient responds to them. And then also some insulin, some, for example, either overnight insulin or for the morning that hasn't been prescribed by the day team, and also, last but not least, antibiotics as well. So these are the kind of most commonest things that you'd be expected to prescribe. You wouldn't be expected to prescribe some new medication for the patients that's like a regular prescription, for example, or anything like that. It would mainly just be kind of either PRN or kind of just acute, stat medications. Now, in terms of anything else, you'd be obviously called about any deteriorating patients, any sudden change in the patient's observations, especially if they use a 5 and above. Any drug chart reviews as well. So, for example, on the wards, the base team or the base ward / the medical staff, they may have crossed off an antibiotics or said for review on the drug chart. Then they might ask you to come and review and see whether the patient is able to take this medication or not. So you will be expected to make decisions on patients that you haven't seen before, and therefore you need to be very diligent in reading up about the patient and whether it's okay or safe to restart some of these medications. And I know this might sound very unsafe, but unfortunately, that is just the expectation in the NHS. And sometimes you'll be asked to rewrite drug charts. This will obviously come very, very low on the priority list, but obviously, if you're not doing anything, then you can go and do that. Some bloods as well, if the nurses fail to bleed them, cannulations, again, for the same purposes as the bloods. Also, NG tube insertions you'll be expected to do as an FY1. Sometimes discharging patients. Now, again, this will come very, very low in the pecking order of things that you should prioritize when you're on call. However, and I will note this, there are some patients who are required to go back to a care home or a nursing home, and sometimes they may be at risk of losing their bed at the nursing home. So sometimes discharge summaries are urgent, and therefore you do have to attend to them. But this is very rare, and it's really few or far between. And then last but not least, you might be expected to actually engage in some complex family discussions as well during your on-call shift. And again, this might be very unfair because you might not know anything about the patient at all. But this is where reading up about the patient and understanding exactly what's going on from start to finish can become very important too. And usually in these kind of scenarios, if they become a bit complex, then I would definitely, escalate it to a senior to come and help you, because some of these discussions can involve, safeguarding concerns and stuff like that. So I think that if you're ever really going to escalate, then I think it would definitely be appropriate in that particular case. Now, in terms of prioritizing jobs, how do we know? When you receive your handover at 5 o'clock from the medical staff or the medical SHO who's on that base ward usually. So, for example, you're on a geriatric ward, and one of the medical SHOs who usually works on that ward comes down and gives you a handover, and they're going to give you a list of jobs to do. Okay, and you're going to need to sift through them and understand what is urgent and what can be left either for the night team or for the day team the next day. And this is where the 6 scale kind of comes into place. And I didn't really think it was that useful early on. But as I'm kind of going forward, I'm starting to really understand how important just having a bit of a framework in your mind really is. So I kind of categorize them as either red, amber, green, or blue. So red is obviously an emergency. So anyone who suddenly begins using a 7 or above, which usually common due to heart rate over 100, oxygen sats suddenly deteriorate to below 92% or 94%. Also, if a patient suddenly has altered consciousness and their GCS just drops for literally no reason whatsoever, and obviously you have a few acute scenarios which specifically you have to go and attend immediately. If a patient is suspected septic, if they have an acute chest pain, obviously that can be a PE, aortic dissection, MI, whatever it might be. If they have a seizure, and if they have a excruciatingly low blood pressure, or as I said, if they fall completely unconscious as well. So that's important to know. And at that point, you would drop everything, drop whatever you're doing, and go and see that patient, okay? Because you might have to put out a medical emergency call for this particular patient. An amber is when the patient shows a slight deterioration, or for example, new onset fever or anything like that. You would go and see the patient at some point, but it wouldn't be an emergency. You can finish what you're doing and then go and see the patient. In terms of the green, this is usually just the routine jobs, drug charts, cannulas, fluids, doing the take-home medications and prescriptions for the patients to go home with, discharge summaries, and also bloods. Discharge summaries are also in the blue section, but as I said, sometimes they can be a bit more urgent. So, I can put them in green or blue, really. Fluid chart updates, they're not really that important, but obviously, towards the end of your shift, if you're free, then I would definitely just prescribe the maintenance fluids for the patient just to continue throughout the night. And obviously rescheduling meds as well. These are usually jobs that should have been done by the base ward. So annoyingly, they are kind of left to you guys. But as I said, if you're very busy, you're not expected to, carry out all of these, if it's a very, very busy on call or anything like that. Okay. So that's just something to note. And in terms of the stop, so once you've kind of done the sick scale, you've decided how sick is this patient really, then you would then determine what the task actually is to do, and just have that in your head. What are you really expected to do for this patient, and then the order of priority of this patient. As I said, that kind of comes with the sick scale as well. And then P is just kind of the plan, and that also comes with the kind of task as well. So once you've seen the patient, and you've already tasked yourself for seeing the patient, and you come up with a bit of a comprehensive plan of what you're going to do, and the if not, you're going to escalate this patient to a senior. So these are kind of things to consider. I'm just going to quickly look at the chat. I just want to see whether I missed anything. So Annabelle asks, when responding to the bleep and you realize that the patient is at their baseline, and explain that there is no need to see the patient, do you need to document this? Yes. Thank you. That is very, very important point. So document, if you're not going to see the patient and you are going to see the patient, in either scenario, document everything. Document the entire conversation with the nurse or the staff that's bleeped you, which can either be a healthcare associate or a nurse, and document the entire thing. Now, obviously, my advice would be, as an FY1 starting off, even if a patient is so-called at their baseline, I would still go and I would still look at the patient and just briefly assess them. And this is just so you can say that you've seen the patient. That would be my advice. And that would usually be an ironclad protection against the General Medical Council if any concerns are to be raised either by the patient or their loved ones as well. So I would still go and see the patient. Now, obviously, as you become a bit more competent and you become an FY2 or a SHO is a bit more advanced in medical training, or even a registrar, then of course in that case, then you can make the medical decision to just say, no, the patient's at their baseline, I don't need to see this patient. So hopefully that answers your question and that helps. Let me know if there's a bit of a confusion or there's a follow-up question to that. Now, in terms of deteriorating patients and when you're called to see one, what are the main things that need to be considered? So really, what is the initial approach? The initial approach is for any patient who's deteriorating, you do an A2E assessment. I hope that everyone knows what that is. If not, you can attend one of our future sessions. This is not just necessarily to plug our sessions, but I think it's very, very useful. So essentially, it's just going through the procedure of any acute patient. You should assess them in that manner: their airway, their breathing, their circulation, disability, which basically is looking at pupils, their blood glucose, etc., and then exposing the patient completely, just to make sure that you're not missing anything. And in the case of fever or very very high temperatures, just to get down their temperature a little bit as well. So these are just things to consider. So that's the initial kind of triage or assessment of a patient that you see. Okay, then you would move on to doing an ample. Just a quick question, I guess, just kind of keep you guys engaged. Does anyone know what ample stands for? Anyone want to put that in the chat? I'll give you guys just a quick minute because I don't think I've asked you guys a question yet, so you guys can go ahead. I think people might be being either being very very shy, or they just don't know what an ample assessment is. I'm not too sure, but I'm happy to go through it. That's completely fine by me. So essentially, an ample assessment is basically essentially a mini history, right, of the patient, just to kind of get a bit of background context in terms of why they might be or why they may have deteriorated in the way they have, or exactly what might be going on. So essentially, it's looking or asking for their allergies and the medication that they're on, their past medical history, and the time that they last ate/drank. Right, and this is basically to assess their hydration status, the precipitating factors to why they might be feeling the way that they're feeling. Is it because of their past medical history, or is it because of a new onset of something else that's going on? And also their allergies as well, just to look for if it could be an anaphylactic reaction. That might be why they're short of breath, or why there's some angioedema or anything like that. And yeah, there we go. Someone's already answered. Perfect. So that's exactly it. And then after that, if you have time, and this is usually more of a secondary review, so it's not initially when you're seeing a deteriorating patient, but once the patient is stabilized, we would then look at doing a head-to-toe examination of the patient to see exactly what went wrong, and what can be prevented in the future, to kind of safety net against any future deteriorations. Then what you would do is, once you've assessed the patient and you've sent off for any relevant investigations, such as, for example, an X-ray, an ABG, blood pressure measurements, bloods and blood cultures, getting IV access, getting your BMs, your GCS score, all these kind of things, and examining the patient thoroughly. You then study the patient. So what you do is you go on the system and you would see everything there is to know about the patient: their past correspondences at outpatient clinics, their past medical and surgical history, because obviously some patients might leave some certain things out, the previous investigations that they've had whilst they've been in hospital or even outside of the hospital grounds, and also their entire admission history as well. So seeing what they've been saying on the ward rounds, because this will give you a generalized picture of what could be going on with the patient. It really is all about context, and I hope this is what you guys are gleaning into this. And then in terms of the remainder of the approach, just looking at when and where to escalate. And again, we will talk about this on the right-hand side of the slide. And then also at the handover, what is pertinent to handover from this deteriorating patient. So just a quick tip: any patient that has deteriorated on your watch from your 5 to 9, please, please, please let the medical staff on the night shift know that this patient has deteriorated. Even if they do become stable again, it will be very, very important, because then at least they have a bit of an expectation, and they might read into the patient, or they might understand a bit more about the patient. So when they go and see the patient on their night shift, and they're called to this patient, everything kind of makes a bit more sense, and they know exactly how to navigate managing or assessing this patient, and things to look for, really. So it's helping out your staff and your colleagues. In terms of the escalation process in the UK, I know some people aren't from the UK, but even people that are might not be familiar or too familiar with the escalation process. So usually as an FY1, your first port of call will be your senior house officer, and they might be able to guide you or help you with certain things, such as, for example, with a difficult cannulation or with an NG tube insertion, and things like this. Okay. The second port of call will be your medical registrar, right? And if things go literally completely balls to the wall, and pardon the swearing, but when shit kind of hits the fan, then you'll be expected to get your consultant on call. And it's very, very rare. Me, in my whole year as an FY1, I've not had to call the consultant to come in. But there are certain indications. So, for example, if you're on urology, if a patient comes in, they've got some Fournier's gangrene, then you'd have to call, the consultant. If a patient comes in and they've got a massive gastrointestinal hemorrhage and they require, urgent endoscopy, you might again have to call your consultant in. So they're very, very specific scenarios, but it might happen. Okay. And really, the main question is, the overarching theme of this is really deciding on when to escalate or not. Okay. And I've come up with a few bullet points. People can feel free, to ask, specific scenarios of when it's appropriate to escalate. For me, I think that the ones that I've listed are quite comprehensive. So usually if the patient is unresponsive to the initial treatment that you've given them, for example, if they're fluid unresponsive, then you would want to escalate this patient if their blood pressure remains persistently low. If it's a difficult interpretation, and this is where I'll give you a massive tip. If you have inserted an NG tube into a patient, okay, it might be enough in your trust, and I don't know exactly how it is from trust to trust. It might be enough that you've got a sample from the NG tube that comes out as acidic, and that might be enough to prove that it is within the gastrointestinal tract, right? Or, and this is more commonly, you'd have to get a X-ray to see the positioning of the NG tube. Now, you yourself as an FY1 would not be expected to determine whether it is within the gastrointestinal tract or not. You will have to escalate to a senior for this. And most commonly, it will have to be a senior medical registrar to see whether the NG tube is in place. Because essentially, if it's not, that patient can die on your watch. So that is very, very important to understand. Also, other difficult interpretations might be if you're not really understanding what's going on with a particular patient's ABG, or a different chest X-ray or an abdominal X-ray in a patient that you're querying a bowel obstruction for. These are all things that can be very difficult for an FY1 to interpret and make a decision on. So in these particular cases, you would be expected to escalate to a senior. Also, if there's complex clinical skills, so for example, a patient comes in with suspected meningitis, you need to do a lumbar puncture. As an FY1, you would not be expected to do a lumbar puncture, and therefore you can escalate to your senior. Obviously, in the cases of cardiac arrest and stuff like that, for example, when you need to get interosseous access instead of IV access, again, you need to get a senior involved, and your medical registrar would be there on the medical emergency calls anyway. So these are just kind of things to to expect. And so you're not really overwhelmed with many, many different things that you probably haven't done or haven't seen before. You've always got your senior on, literally just one call away. Also, if in use of 5 or more, that is kind of my boundary of when I would escalate to a senior. And that's what I've seen on A&E currently. If it's in use of 5 or more, always escalate and discuss with the senior. And if the patient suddenly deteriorates, always let your senior know, because there might be something going on that you haven't considered. Because at the end of the day, they have a much clearer picture and they have much more experience under their belt that they can touch on or kind of give advice to. So yeah, that's just something to consider as well. For complex family discussions, as I kind of alluded to earlier. And then the 4 other, key scenarios in sepsis, if it's an acute onset chest pain, if it's a seizure, and if there's an anaphylaxis. In these 4 scenarios, do not hesitate, call a senior or put out a medical emergency call. Okay. And now, when you're handing over to the night team, or when you're receiving a handover, what are the main things that you'd be expected to ask of from your medical colleagues? So, number one thing, there is a kind of framework that you guys may have heard of that's called the SBAR, which is the situation, background, and then the assessment, and then the recommendation. I think that the SBAR is a bit too vague. So I use this, and this is the handover method. This is kind of all over the place in terms of the order, but it does very well to outline exactly what you need to be thinking about. So you want to be thinking about the main headline, which is where is the patient, number one, what is the patient called, okay, and what is their NHS number, but also what is the suspected diagnosis, what are you suspecting is going on in your own words, okay? Is it a infective exacerbation of COPD? Is it a GI bleed? Is it just as simple as a hemorrhoidal bleed, so just basically lower GI bleed. So just think about these things, and that's the main thing that you want to be asking: what exactly is going on with the patient? What are you suspecting? And also, what are the active issues? So what is going on with the patient currently? What are they currently experiencing? How are their observations doing? And all these kind of things. Then the background of the patient as well. So knowing, for example, is this patient a known COPD patient? What exactly are they? Are they scale 1? So are we aiming for saturations of 94 to 98%? Or are we aiming for saturations of 88 to 92%? So what exactly are we expected to do with this patient, and how are we expected to manage them as well? Because that can come from the background in terms of suspecting exactly what could be going on. What are the tasks? What do you want me to do about this patient? Okay. Is there anything that's worth chasing in terms of the results or anything like that? Or is it just that you want me to review the patient? What exactly is it that you're looking for with this handover? And also just knowing as well, and I think this is very pertinent, a lot of people forget about this because they end up kind of repeating procedures and repeating things that the medical staff have already done. And especially in a limited time period, you don't want to be repeating bloods on a patient. Asking the medical team that's handing over to you, what has been done so far? Okay, what investigations have you already ran for the patient? What have you already assessed? What have you found with this patient on assessment? And therefore, what are you expecting me to then go on and do? And last but not least, what is the escalation plan for this patient? So, and that means, again, and we already kind of touched upon this, what is the ceiling of care for this patient? Are they just a ward-based ceiling of care? Are they end of life? Are they just only for single organ support? So therefore, would they be, for example, referred to only a high dependency unit? Or instead, are they for multi-organ support? So therefore, would they be referred to ICU for more invasive management? So for example, invasive ventilation or dialysis, etc. Okay, and things like that. So these are, kind of things to consider as well. And last but not least, are these patients, for resuscitation or not for resuscitation? Do they have a DNA CPR in place or not? And this is really, really important because ethically, if you start, jumping on someone's chest and they've got a DNA CPR in place, you're going to be in big trouble. Okay, so it's just something to consider. The main things to avoid, and this is also to tell your colleagues to avoid as well when they're handing over, a lot of vague phrases. You might be asked to cast an eye on a patient. Now, what does that truly mean? Do you want me to just look at the patient, or do you really want me to review them? And if I do review them, in the case that something does go wrong, what are you expecting me to do? Okay, and these are really things to interrogate the person who's handing over to you on, because at the end of the day, this is going to be a big responsibility. You're obviously taking care of someone's life. All right. So even if the handover takes a bit more, a bit longer than usual, I think it's very, very important to do a deep dive and investigation in terms of what they're expected to do. How is the patient stability wise? What's already been ran? What investigations are pending? And what you expect me to chase up and what you expect me to do. Okay, so please, please, please don't hesitate to ask a lot of questions to your colleagues who are handing over to you, because otherwise you regret not doing that. I've just put a very, very brief example of a very good handover in the corner. And this is how, I've learned to hand over, but trust me, at the start of FY1, my handover was nothing like this. And for example, you've got a patient called Mrs. Patel. She's 76 years old. You've got the location, so you've got the name, you've got the, you got the patient's age as well. And what have they been admitted with? What has the patient got? She's got an AKI, and it's secondary to urosepsis. So you got the story right there. Okay. And the background is that she's got recurrent UTIs. So obviously you're expecting that the patient's already been managed on antibiotics and IVI. But obviously you'd have to ask that specifically. Has the patient been started on antibiotics? Have they been started on fluids? What are their observations like, etc.? How is the assessment currently? What is the main issue at the moment? Why are you handing this patient over to me? And for example, this patient is oliguric. Okay. And the other thing that's really good about this handover is it says specifically that this patient is for full escalation. So we are deeming this patient fit and well. And if worse comes to worse, she goes into multi-organ failure, she will then be referred to the intensive care unit, also known as ICU. And then what are they expecting you to do about it? So they're handing it over as just please repeat the bloods on this patient and then escalate to the SHO if this happens. And that's amazing. Okay. They're literally telling you exactly what to do. They're outlining, what the escalation plan is, how to de-escalate it. And, obviously if the user needs come back as normal, then we don't do anything. And if they don't come back as, if they come back as abnormal, to a particular number or anything like that, then we escalate. All right. So this is very, very good. And that's exactly how a handover should be. They should be telling you all the things that you're expected to do with this patient. All right. And that's it. That's the talk. Exactly 1 hour. So I'm happy about that. Please, please, please fill in the feedback forms. They really, really help me. And they also help Mind the Bleep as well. And they help facilitate these sessions that hopefully you guys found very useful. Just quickly, while you guys are filling in the feedback forms, I will answer the remainder of the questions that have popped up on the chat. So, someone says, my hospital uses paper notes. Would I need to go to the ward to find their notes to document this in? Um, Yes. So if they're paper notes in terms of documented, so my hospital uses electronic notes. With paper notes, I wouldn't be too sure exactly, but from what I understand, is then yes, you would be expected to go to the ward, get the notes, and document it, which might sound a bit, kind of long-winded and stuff like that. But it will definitely be worth your time because if it's not been put on paper and it's not documented, then unfortunately it didn't happen. Just to answer Hassan's question, can you elaborate the point on family discussions or complex family discussions? At what point would it be complex? So, I'll give you an example of a complex family discussion. So, for example, whether a patient would be for DNA CPR. Now, you would be surprised, but if a patient is deteriorating and they're quite old, I have seen it before where a patient who's got a myriad of different comorbidities going on. So, for example, if they've got, let's just say, a background of metastatic, lung cancer, okay, and they're deteriorating. However, they don't have an escalation plan in place, right? And the family's at their bedside and they're going to be asking you questions. They're going to say to you, what are you going to do with my mum or my dad? Okay, and you're going to have to stare them blank in the face and say to them, if I'm being honest, I don't really know, because you're not going to know as an FY1 whether the patient is for full escalation or not. Of course, if it's metastatic lung cancer and they're old and they've got multiple comorbidities, 9 times out of 10 they're not going to be for ICU, and they probably wouldn't even be for a high dependency unit. So they might only be for a ward-based ceiling of care. However, you're going to have to be expected to explain that to the family. And that's where it gets very difficult. So it's really, really useful to get a senior involved and to help you in these kind of discussions. Because otherwise, it could just end up being you might end up, for example, relaying the wrong information, making a wrong decision or anything like that in terms of, what escalation of care the patient is for. So I would definitely recruit a senior for these kind of complex family discussions. And that's just one example, but there can be many. Hopefully that makes sense. I'm just going to answer Annabelle's question. So, if you are holding the crash bleep, are you still doing ward cover after 5, or are you solely doing crash calls? No, yep. So you're doing ward cover and crash calls. So you're expected to do both if you're carrying the crash bleep. Whereas if you're not carrying the crash bleep, you're only expected to do the ward covers. Does that make sense? Let me know, by the way, to Hassan and Annabelle, and I don't know who your name, but it says the username is Dark Skies. Let me know, if my answers are sufficient and or whether you need a bit more detail. Ella asks, in what situation would you pull the buzzer to get more help? Um, Anything that you are unsure of when a patient is deteriorating in front of you, right? And by the way, this is where your clinical hat comes on, right? And this is what you've been taught during med school. At the end of the day, you need to be confident that you know when to recognize an unwell patient. When the patient is unwell, right, and there is a sudden deterioration in their, in their function, and most likely that will be when there is a altered consciousness and their GCS drops. In that case, then I would pull the buzzer. Okay, so usually if their GCS drops below 15 out of 15, and they're acutely deteriorating, then I would pull the buzzer and I would put out a medical emergency call. Does that make sense? If there's no more questions, I'm happy to end it. But I'll give you guys maybe just a few more minutes just to ask anything that you'd like. And maybe at 5 or 10 past, I'm happy to end the stream. And as I said, this will be all uploaded to YouTube immediately. Okay, perfect. Good. Okay, I'm glad. I'm glad that everyone's been finding this session kind of useful. please tune in for the next one. It's going to be happening next Thursday. I'm not sure exactly what they'll be covering, but it'll be something very, very important. And I know that you guys are going into your induction weeks as well, so hopefully it'll be very useful for you guys. And yeah, please fill in the feedback forms. I'm going to leave this up for another couple of minutes, and then I'll end the stream. So thank you guys for tuning in. Oh, we got one more. Okay, you literally just came right at the last minute, just before I end it. So, just quick question: if a patient is in peri-arrest, do you put out a medical emergency or crash call? Yeah, so it would be a medical emergency call. Yeah, so that's essentially if. I mean, to be fair, actually, you know what? It's a good question. If they're in peri-arrest, then what I've done, to be honest, is I've put out a medical emergency call if they're in peri-arrest. But it's the same thing either way. It's a triple double two. So I think it's just like in terms of just you know you're confusing the names really. It's just a crash call is a medical emergency call. That's what we call it. We just call it a met call essentially. So it's kind of synonymous with the same thing. That's in my hospital anyway. I'm not sure how it is in other hospitals. MR75 asks, what are the most common mistakes FY1s make on call, and how do we avoid them? I would say the most common mistakes is assuming you know more than you actually do know, or kind of overestimating your competencies. So I can't really say anything specific if I'm being completely honest with you, but I think that, and what I'm kind of trying to get at is don't assume you're more competent than you actually are. Meaning, don't be scared or don't have too much of an ego as a barrier or getting in the way of you asking your seniors questions. Please don't hesitate. If you're if you're unsure of something or you're not 100% sure of something, even if it's 99%, ask a senior because you will not regret it. However, you will regret it if you don't ask. So that would be my biggest advice to everyone. And I hope that answers your question. Sorry, I couldn't give you something or a specific scenario or specific things that medical students or new FY1s do struggle with, but there isn't anything that comes to the top of my head. Okay. If that answers everyone's questions, I'm happy to end the stream now. If there's any more questions, then save them for next Thursday, where we'll be doing this kind of session at 7:00. It'll be on YouTube again, so tune in with us then. In the meantime, thank you, and please fill in the feedback forms. I sound like a broken record at this point, but it really helps me out. So yeah, see you guys later, and hopefully you guys join the next one.